screening of retinoblastoma. Dan, you can share your screen. He is the current president of International Society for Ocular Oncology, and he's from MD Anderson Cancer Institute.
Santosh, if I can make a last comment, please.
Yeah. Go ahead.
Yeah, so the one more other difference which I wanted to mention about the plaque brachytherapy with iodine and ruthenium. If you have a thicker tumor, more than 7 millimeters, so it's preferable to go for a iodine, which is better in dose distribution compared to the flat tumors. So flat tumors, you prefer to go for ruthenium. So that's an advantage of a gamma radiation. But again, I repeat, the effect of radiation would remain the same.
So we'll go with Dr. Gombos, and the discussant will be Dr. Sumit Lahane from JJ Hospital, Mumbai.
Thanks. Can you just confirm you can hear me and you can see my slide?
That's right.
Thank you. Well, it's always an honor and privilege to be at the All India Ophthalmology Society meeting, and I'm very grateful for this opportunity to speak to you today. My assigned topic was screening in retinoblastoma. Do we have consensus? And for those who don't have time to hear the answer, let's just get straight to the answer, which is maybe, sort of, kind of, well, yes. And I would argue it's always fascinating to see if we can ever truly find consensus in anything in retinoblastoma. But I've been very pleased at the screening and the consensus that we have developed over time. This is our center in Houston. This discussion at some level happened with the publication of this paper, which many of our colleagues are on this talk. It was a screening manuscript that we published in the Journal of Ophthalmology. And while there were a number of colleagues who were on this paper, I'd really like to highlight the role of Alison Scallett, who really motivated many of us to get this paper and its contents in publication, and Dr. Chavez Barrios at Houston Methodist, who spearheaded this. And the concept of having sort of guidelines or screening parameters is not new. I remember being a medical student working in New York City and saying, is there a published mechanism by which we can, screen patients? And of course, we know that there are patients who absolutely, benefit and need screening. These are patients with a family history of retinoblastoma who, compared to the general population, have an elevated risk for this disease. And we know by consensus that if we diagnose this disease when tumors are very small, we absolutely come and reduce the need for more invasive therapies, whether it's intravenous, intraarterial chemotherapy, enucleation, or radiation. But then the question arises, and this is how this paper developed, when and how do we screen? And that was really the question that Dr. Scallett asked many of us, Dan, how often do you do it and when? And then, of course, why do you do that? Which for many of us is, well, this is how the person who trained me taught me, so this is what I do. But there were many factors over the years, and even I remember these things coming up when I inquired as a medical student nearly 30 years ago, why didn't we have such a document? Well, first level, people are not keen on having, quote, guidelines per se. They're very concerned that if a guideline says that at age X, you need to do this test and it's not done, it opens up the practitioner to litigation. And so there's enormous hesitancy at that level. Then there was the concern raised, well, we may have certain approaches that we may prefer in certain centers in North America and Europe, but there are enormous challenges in following certain recommendations in rural areas and lower middle income nations. One example of which is access to skilled pediatric anesthesia, which in some countries is quite dangerous because there's very little access to pediatric anesthesia for exams under anesthesia. And then finally, we wanted to make sure that if there was such a document, it wasn't just based on what people did, but that there was a scientific basis for what we were doing. And so that became the goal of this concept, was to come up with a consensus paper. But I would point out it was a consensus paper to try to provide guidelines for screening in the United States with the primary goal of early detection. This is not patients who are already undergoing therapy. These are patients who are at risk and therefore have an early detection approach. And it should be scientifically based as much as possible. So we created a consensus panel of the individuals you saw. And our first approach was to say that we were going to use risk stratification. So this is common in cancer medicine, where we administer screening based on risk. And those patients who are at higher risk are more likely to get screening than others. And we know very clearly in retinoblastoma that we can individualize that risk with genetic analysis, both testing and counseling of the family. And I will always say of the family, because in retinoblastoma, this is a disease not of a patient, but impacts everyone in the family. So one clear area where we were able to get certain consensus, and I don't think this is room for disagreement, is anyone who's at risk for retinoblastoma above the population risk should have some form of screening with a dilated exam by someone with experience in retinoblastoma. We didn't want to limit that to ocular oncologists. So we opened that up to all specialists who can perform and know what to look for. And we recommended frequent screenings, particularly young age, because we know that those highest risk patients are at higher risk based on age development, that tumors decrease in frequency over time as the child gets older. But we also strongly advocated genetic testing and counseling. Counseling being just as important as testing, I might add. A lot of times patients just get a test, they don't know how to interpret it. And the other thing we point out in the paper is that genetic testing should be afforded to patients who have unilateral or bilateral disease. And just this week, I learned of families that are getting miscounseled because some practitioners said, well, your child has unilateral disease. They don't need to be tested for the genetic form of this disease. Completely not consistent with good care. The next thing we did is we just took some base scientific information of what we know. And what we know is the risk of retinoblastoma, even without genetic testing, just on proband analysis, such as this. So if you take the proband, you know whether it's bilateral or unilateral, you can identify the relative risk in a very simplified model and identify it as high, intermediate, or low risk. This requires no genetic testing. This requires just family testing. We decided that particularly the high and intermediate risk children would benefit from a more intensive approach. But we can't deny that in 2022, genetic testing plays a significant role. And I think most centers, if you're going to call yourself a center, you must involve genetic testing. You must involve counseling, because the impact of a family, if a child is RB1 positive, and then a family member is tested, can be the difference between no screening or quite aggressive screening. And it's still sad that in the United States today, we still fight for genetic testing with some insurance policies. And another goal of this paper was to support genetic testing. So the group came together, and this is, of course, where it's a little less scientifically inclined, but there was an attempt to try to stratify between high, intermediate, and low risk. And of course, this came back and forth between the team, but a general consensus developed that you can see here, and this is ultimately what was published. We tried to determine between sedated and unsedated and sedated exams. And we certainly concluded that risk stratification is a beneficial approach with refinement of genetic testing. And I would point out that the schedules that we listed are general guidelines. We left it up to the primary practitioner to decide ultimately what they were going to do. We did not write a preferred practice pattern because we didn't really have the data for an absolute preferred practice pattern, but we certainly recommended exams under anesthesia for any child who is unable to participate in an office-based exam or to allow thorough examination of the retina. Well, what's been some of the feedback? Because you asked me if there was consensus. Some of the feedback's been very positive. It gives certain practitioners, particularly those in some rural areas, a much greater structure and template for follow-up. It allowed for justification of EUAs, and as many of you know, we had significant challenges in getting patients to the OR during the pandemic. We had to justify each and every patient at our hospital who was put to sleep during the height of the pandemic, and papers such as this justified the role of screening high-risk patients because of the risk of disease. And we justified the role of genetic testing and counseling with insurance providers including those with unilateral retinoblastoma. And the fact is, we had enormous endorsement from the highest levels of the societies listed here, including the American Academy of Pediatrics, Ophthalmology, and the Society of Pediatric Hematology and Oncology. So I think that in and of itself speaks to the consensus nature of this manuscript. But there have been negative comments made, and I'll point them out. They've been published. What is the duration of which we need to screen? And some individuals, and I would advocate this, is that at some level, any child with retinoblastoma should get an exam every year. It doesn't need to be an EUA, but it needs to be an office visit and a review, especially if they're unilateral or they're ultimately going to have family members of their own. There's certainly utility in doing an office visit. When should you stop doing exams under anesthesia? That's been the most controversial aspect of this manuscript, with our European colleagues, particularly in the Netherlands, advocating that we recommended stopping EUAs up to the age of 7, but there are many centers who do that at a younger age. And there's some data to suggest that it's not unreasonable to stop at maybe 4 or 5 years of age. And that's an open and valuable discussion to have. And then some centers have argued that we shouldn't have risk stratified, although again, very commonly used in cancer management, that you're either at risk or you're not at risk. So my final slide here. Is there a consensus on screening? When it comes to the valid points, absolutely yes. We need to stratify our highest risk patients. We need to offer them genetic testing and counseling. EUAs, if they can be done availably and safely, should be done. And the highest risk patients should be seen early on and frequently. And I thank you for your attention.
Thank you very much, and very wonderfully summarized. Very nice talk. Sumi, do you have any points?
Yes, sir. Yes. So, good evening, everyone. Dr. Dan, that was really nice talk, and we went through your paper. It's very beautifully done. Thank you for giving us some insight about the screening, sir. I have a few questions where you have risk stratified and given them as a higher, intermediate, and the low risk. So, should we have any algorithm instead, or along with that, like where like genetic testing is not so frequent in India? For certain countries, it may not be very possible, or many times even the parents are not so willing. Could be a cost thing or other bars, because of which it is difficult. So can we have some algorithm regarding that, where we can do certain steps and then plan for screening?
Yeah, absolutely. If you look at the slide that I showed with the genetic tree, that high, medium, and low risk is based without any genetic testing at all. So the reason we put that in is because we understood even in many high-income countries that genetic testing is sometimes an obstacle because providers won't pay for it. So that's sort of a national issue. And we certainly know that, there are going to be some patients that have up to a 45, 50% risk of disease. Those patients should absolutely be at the highest level of the tree. But then you do have this sort of cohort that's above 1% and, less than 10%. And so how do you find that balance? And so we sort of lump that in, but, we have to be cognizant of the resources in any particular environment. And that's why I think we sort of put it at the highest, medium, and then lowest risk. I think you could argue if there are really significant limitations in resources, and we saw how the pandemic significantly impacted resources, that you have to stratify those patients. So again, I think just, whether bilateral, unilateral, family member, proband, that you can get a lot out of just that basic information. And if you don't have a geneticist, then that risk stratification falls on the ophthalmologist.
And sir, do you recommend, like, it's a consensus that we have come through across the experience of multiple centers in the United States and other countries? So should we have any follow-through study following the guidelines that has been given in your article, and then try and give a preferred practice pattern? As you said, these are not a preferred practice pattern, these are guidelines. So can we go ahead, one step ahead in what primary work have you done?
Yeah, I've had very nice discussions with Alison Scowlett, and we took to heart many of the comments that have been published by people like Annette Moll and David Abramson, and there's certainly an opportunity to maybe improve on these things. I think particularly this age between 5 and 7, you know, both I and Matt Wilson have seen retinoblastoma in a screening patient above the age of 5, and it just happened to me within the last 2 years. So after 21 years in practice in Houston, I never saw it. Matt Wilson said he had seen one. So this is sort of my anxiety about that rare between 5 to 7 age range. But there are others. And again, Annette Mol has really good data from the Netherlands to suggest screening under anesthesia for that age may be a little bit too much. And I think that's a valuable point to perhaps circle. We should not be so wed to these recommendations that we can't be open to improving them and modifying them further.
So one last question from my side. So how do you rate, or where is the place for ultrasound in the screening program, where this EUA is little not acceptable to everyone? So does the ultrasound hold any place?
I know that Lynn Murphy was a big advocate of office visits, combining ultrasound in cases where he could not do exams under anesthesia. I have never felt comfortable an infant without looking at the retina and documenting it and going around and doing a 360-degree exam. But certainly if one is in a situation where for any enormous reasons they cannot perform an exam under anesthesia, an office visit augmented with an ultrasound is certainly better than an office visit not augmented with an ultrasound.
Thank you so much. Thank you, Dan, for sparing your time, and Sumit for your wonderful